Okay, I'm going to talk about our early experience. We have been users since 2022, so this is just going back to the start of the program and thinking about how you can potentially integrate this into your own practice. Obviously, the main goal of Connectomics is to improve your oncofunctional balance. And I think that, as many of the speakers outlined today, it's more than just simple tractography, especially with some of the resting state fMRI work. And then there are various programs that can do tractography, but a lot of them don't accommodate, for example, for edema. So you may be mapping out things and there's a lot of artifact and the tracks drop out where there's edema. And so that can be a big problem, especially for a tumor program. And then the other thing is how you integrate this into surgical planning. And we'll talk a little bit about that through some cases and how this leads to better functional outcomes. Our first 20 cases gave us some insights. The main thing is that it helped us identify surgical candidates. And mainly what I mean by that is some people were billed as maybe this is not safe to operate on, and then you map them out and you say, oh, no, I think I can safely do a resection. And the other thing is the opposite, that you feel maybe I can take out this tumor, but then you map them out and you realize I would disrupt a lot of very important pathways that might lead to a functional status that is not compatible with what their goals, and then you may opt for not necessarily doing as aggressive of a surgery. And then we'll also talk a little bit about the financial side, because as great as this helps you with your pre-surgical planning, I think Dr. D'Amico really pointed out some things that you have to tell leadership in order for them to have a buy-in. So we'll go to some case examples. So this is some problems that you can encounter as a tumor neurosurgeon and how this platform can help you. So problem number one, awake mapping is not feasible. So this is common. A patient comes in, a large left frontal tumor or left temporal tumor. And a lot of times, I think classically people think, I'm going to do an awake craniotomy. Many of you who've seen these people with large tumors know that a lot of them they have such disorganized speech pathways that they cannot participate in awake mapping. Their speech is so badly affected. And this is because this woman had a lot of edema and she would not be able to tolerate an awake surgery. And so mapping her out and doing this without an awake pathway, I think, oops, I'm not sure what happened. Okay, I think one of the cases that really helped me become more confident is I had a patient who actually only spoke Spanish, and we did not have the capability to do awake mapping in the operating room. So that was one of the first patients that I'm like, okay, I'm gonna take the leap. Do I really believe in connectomics? Because I'm not gonna be mapping them. And so this is another example. And then for our program, these patients, we do a next generation sequencing. So you can see that this is a very aggressive subtype of GBM, a TORC promoter mutation, CDKN2 co-deletion. So again, this is not your run-of-the-mill GBM. This is a very nasty one. And then we also send out functional assays. So we do drug screening on ex vivo organoids. And so you can see this is her response. And so look at temozolomide, which is standard of care. Her ex vivo profile shows that there's no response in her tumor. So we actually did her asleep. She ended up having a pretty good outcome. She had improved speech because as the edema went away, she had a pretty good quality of life, lived. This is recurrence almost a year later, and she had contralateral recurrence. So for this one, we did a supraorbital approach, and then again, the same iterative pathway to try to help her live longer. But again, the index surgery is most important for overall survival, and having that confidence to actually rely on connectomics over some traditional things like awake mapping. So here's another problem that can be encountered is patient hesitancy. So this is a patient who had a young man, a primary breadwinner for his family, and he's a machinist. So his vision was very important. So he had an oligodendroglioma resected years ago. Now he has recurrence, and he's like, I'm so scared to get surgery. If it affects my vision, I can't have it. And so this is just an example of using the tool to tell the patients, no, it's going to be safe. And I do incorporate it into surgical counseling so that you can actually physically show this to the patient and say, look, this is your tumor. This is a vision pathway, or as I call them, highways to my patient. And you can safely resect this and you're not going to have a deficit, which is really important for some people. So it can address that problem as well. And then talking about recovery. So default mode network and salience network are things that on traditional mapping software you may not get insight to, but with Connectomics you do. And then you can start to see tumors that are involved in these regions and having really candid discussions with the patient and their family about, well, this is likely what you're going to be like after we take the tumor out. And for some people, they opt for just a simple biopsy, or sometimes in extreme cases, they opt for no surgery and just to let nature take over. And then another thing is evaluating surgical candidacy. So sometimes you get a patient transferred in and they have a tumor and they may have been told by another surgeon, this is not resectable, this is in your motor strip. And so again, mapping things out. So you can see that if you map this out, the cortical spinal tract looks like it's is anterior, and then you can confirm that with intraoperative monitoring as well. And then here's another example. So this is a brain metastasis when some people may argue, this person was densely hemiparetic, and some people may think, okay, I'm going to just give them radiation. I tend to be a little bit more aggressive. If you have a neurological deficit, I feel, and you have all this edema, I feel like radiation just is very, very slow, and you're just limping around for like months. And I guess I like open surgery over radiosurgery. Sorry to the people who are radiosurgery folks. So for this person, I'm like, if I can make you walk again, I'm gonna take you to surgery. So here, looking at that picture statically, you're gonna say, oh, maybe that's not safe. But then you map it out, you're like, oh, actually this is gonna be safe. And this came to the surface, and again, got a good resection. Their edema resolved faster. They're walking earlier. They're not just lingering around waiting for radiation to work for like 2 months. And then integration with other platforms. So sometimes you're not necessarily doing open surgery. You may be doing laser ablation. And this is also really important. So some of the really good work from Washington University, St. Louis, if you are familiar with laser ablation, there are different treatment dose therapy lines, so the TDT lines, and white means it's really, really dead, but then there's blue and yellow, and the question is, if I get the heat really close to some fibers, is it okay? Like, which treatment dose line, how close can I get to these fibers? And it's important to know that. And you can actually upload connectome data into your laser ablation workflow. So then you can start actually thinking about, okay, well, how far can I push this ablation without disrupting things? And so this is one of the first patients done where we used Connectomics in combination with laser ablation. And so again, we started in 2022. I think some things about implementation is having continuing to work with the MRI department, because a lot of times with protocols, they may forget to send the correct type of imaging, and then communication with PACS. So you have to have kind of interval check-ins to make sure those processes are working well, providing resident education, and then having grand rounds lectures. We had Dr. Hampt come and visit us and show us like what work he was doing, just to reiterate, you know, this is what people in the field are doing, and this is how it's helpful. And then the other thing is leveraging the technology to improve visibility, advertising that, hey, we have this new brain mapping technology. This is how it works, advertising to referring physicians, etc. And then almost every year, I go through the process of getting this approved by the budget. So thank you for Omniscient for helping. So this is when we started to look at some data of our early experience of saying, okay, we are getting incremental cases that are increasing, and starting to look at those patients that were billed as non-operative but then converted to operative based off of their mapping. And then also really tracking our neurodeficit rates. So then going from decreasing length of stay. So we typically do not put people in the ICU post-op. So we put all our patients on the floor unless there's something unusual, even posterior fossa cases. But still, decreasing the length of stay is still very important. And that translates to cost. So in the end, showing this to the boardroom, as one of the first speaker highlighted, that you have to actually advocate for this technology and saying, okay, yes, this costs however much money for the subscription, but this is how we're estimating that we're actually making a profit for you. Because again, the way the hospital sees this technology is a little differently than you. So in the end, then summary, the lessons learned, definitely helping you decide when you can maybe push the boundaries, like in terms of maybe I will go for the resection, and feeling a little bit more secure. Awake craniotomies, I do much less awake craniotomies. That also translates to money, because OR time is money. So the shorter your cases are, the better. I still have not found an awake craniotomy protocol that is short. It's a huge setup, and you have people in the room and talking to the patient. It just takes so much longer. So you're cutting down hours of time. We also did present that to the budget of how many awake craniotomies we used to do versus now, and how that translates into, again, saved money. And then thinking about how this can be extended beyond tumor. Our next phase is thinking about using resting state functional MRI for our brain injury patients for prognostication, because sometimes they linger in the ICU and it's really difficult to have those talks with people about, hey, is this person ever going to wake up? Are they going to have a meaningful recovery? Or we should not do the trach and peg. So I think that's what we're very much interested in at our center. That's the next phase. But there are other capabilities such as neuropsych, AVMs, cavernomas. Obviously, the work from Miami with the skull-based tumors, just very amazing stuff coming out. And again, trying to show the health system's value for when you go to those boardrooms. And lastly, just in the end, I think it just helps you in terms of increase your surgical volume and improve your outcomes. So thank you so much.